Okay, here we go again. It's Curtis once again, Chapter 10, Medical Emergencies with Emergency Medical Responder. We're going to talk about some EMR stuff today, guys. So, talking about some medical emergencies. Now, introduction. So, some of the things we're going to talk about. Angina pectoris. I know what you're thinking. Curtis, wait a minute. I didn't take a foreign language class. I don't even know what you're talking about. Lucky you, though, we can figure this thing out. So angina or angina is pain. Pectoris is chest. So we're talking about chest pain. That's what we're talking about, is just some chest pain. Maybe it's because somebody hit that person in the chest with a bat. Maybe it's because they're having a heart issue. Maybe it's because they have an infection in their chest. Who knows? The thing is, they're having chest pain. So that's what we're talking about. Heart attack, congestive heart failure, dyspnea, another word for difficulty breathing. As we've talked about, this medical terminology stuff, man, it's a whole new language. So dyspnea, difficulty breathing. Asthma, stroke, hypoglycemia or low blood sugar. Hypo being low, glycemia being blood sugar. And now we're talking about low blood sugar. And then diabetic coma. That can be because it's low or maybe because it's high. But diabetic coma, typically we're thinking maybe like DKA, so diabetic ketoacidosis. But moving on to abdominal pain, so the tum-tum hurts. So treating patients with medical conditions obviously can be very challenging. Not only sometimes they're not very good explainers, sometimes, guess what, we're not very good questioners either. So all of this, and then we just have how intricate and complex the body is. But EMRs, we got to be able to treat medical patients. We got to prepare to treat these medical patients by studying what we know. So what we're saying is the signs and symptoms and treatments of each condition. So we're able to kind of get us a roadmap of, hey, this is what we think it is, or this is what it is, and this is how we're going to get there. Much like a roadmap getting to a call or getting to your vacation, you're going to know the roadmap to get there. We're going to know our roadmaps to get to the end, which is a patient with a heart attack or a patient with an asthma attack, of getting them to the ER, hopefully alive. So guess what? It's back. Patient assessment sequence. So scene size up, still all the same. Nothing's changed. Primary assessment, history taking, secondary assessment, reassessment. So hopefully you still remember those. It was just last time, whenever that was for you. So it wasn't that long ago. Patient assessment in medical emergencies. So we're going to, one of the things we need to do, review our dispatch information. We use that information to help us decide which problems are likely. So, when someone calls in and they give us something, they say that they're having an asthma attack. Well, what is it that we could just want to know on the phone or in conversation about someone having an asthma attack to find out that maybe, is it really asthma? Well, do they have a history of asthma? Have they taken any asthmatic medications? Those are a couple of good questions. Your patient's history shows you a lot, can show you a lot about what's going on currently. That's why that's one of those big things, is that medical history. Carefully assess your scene to identify pertinent safety issues for you and your patient. We need to figure this stuff out. Scene safety is a big thing that we're going to pay attention to. So as we move forward, we start doing that primary assessment. We want to start to form that impression of our patient's problem. So what's going on? Maybe what's going on? Why is it going on? What can we do about it? Is there a life threat here? All of that kind of stuff. So as we get that first impression, then we move on. We start determining their responsiveness, right? We've talked about that, AVPU, introduce ourselves, check their ABC. So if I go in and I look and someone looks at me, they make eye contact with me. They're sitting in a chair in their living room. They're apparently, they recognize me walking in. I can see that they notice that I'm there. I would call that probably alert. I introduce myself and they introduce themselves back. And you say, what's going on? And they start telling you right away. We can assume they're probably alert and oriented. Now, they may say something crazy, and so they're a little bit confused, but they're still alert and oriented, maybe not times 4. We'll talk about that later. But they can be alert and oriented and still be slightly confused. Then we're going to check their ABCs. Well, she says, my name's Margaret. I'm having a really hard time breathing. It's been going on all day. Well, what did we just find out about ABCs? She's speaking in long sentences. Her airway apparently is opening or is open. And by looking at Margaret, we can determine with some skin color, kind of maybe some circulatory issues. If she has maybe she might have a good blood pressure. Or is she pink, warm, and dry, or is she, cool and mottled, or what? And then we acknowledge that chief complaint. So we say, okay, you're having shortness of breath. How long's that been going on? Tell me about that. Those open questions, right? So tell me about that. Not, is it hard to breathe? Because that's just yes or no. So usually when we start talking about this, it's going to be best to obtain a medical history on a patient experiencing a medical problem before you perform your secondary patient assessment. You want to get all of this stuff knocked out fast. Talking about getting your sample, all the things that we talked about. So our signs and symptoms, our allergies, our medications, pertinent past medical history, last oral intake, events leading up to it, all of that stuff. Just reviewing samples in case you missed it. But we want to get those vital signs. We want to perform an ongoing assessment, especially if it's going to be a little bit maybe before the responding unit gets there. We want to make sure to go ahead and do a reassessment after we've gotten to that point. So general medical conditions, they can have different causes, yet result in similar signs and symptoms. I mentioned off about 5 different things of why someone has chest pain. Everything from some congenital anomaly, right? Meaning they were born with some little weird thing, to a cracked rib, to heart attack, to an infection, lots and lots of things. Anxiety can be a big one. So we've got to learn to recognize these signs and symptoms, as well as those guidelines, these kind of general treatment guidelines, so we can provide immediate care. So we almost has these kind of, when someone tells you that they're having chest pain, in my opinion, one of the things you might do is say, okay, it's a heart attack until proven otherwise. Then you go in there and you find out, does it fall in line with some heart attack kind of signs and symptoms? Are they clutching their chest? Are they telling you that it's crushing chest pain? Are they telling you, that they're having difficulty breathing and all? And, well, no, I was hit by a baseball bat. Well, that kind of starts to rule out that it's not a heart attack. So what we're doing is we're gathering up you're being a detective and gathering up all this information, putting it in there, sorting through it, and allowing it to, based upon our knowledge that we're learning and based upon our histories of the calls we've ran on, it allows us to kind of shoot us out of this place that says, this is probably the direction that we're headed. So initial treatment can stabilize a patient until other EMS and hospital personnel can take over. So if we're talking about, so let's just say we walk in and Margaret, she done hit the ground, right? She fell out. She's quit breathing on us and everything. Well, what do? We start CPR, right? We shake and we look and we listen and all that stuff. And we notice Margaret, she just quit talking on us. And now her color is turning crappy. We feel down for a pulse. We don't see a pulse. We see no air movement. And we start CPR. And we continue CPR until the other EMS and hospital personnel can take over, whatever that means, whether that means the responding ambulance or maybe we're on an ambulance. So we're now going to the ER or whatever that means, whatever that next thing is. So we said the ABPU, we mentioned about that, but we're talking about altered mental status now. Okay, AMS or altered mental status. So basically something ain't right. So we're kind of what our curriculum says, a sudden or gradual decrease in their level of responsiveness. So things are just getting a little bit worse. Maybe it's because they've had a stroke, or maybe it's because they've drank too much, or they've done some drugs, or whatever they're doing, but things are changing. So to assess this condition, we use that scale that we've talked about and that you have up there, the AVPU scale. So awake and alert. An alert patient will answer simple questions accurately and appropriately. We're talking about the person, the place, and the day. Now, one thing to think about, if you happen to work on an ambulance and you go into a nursing home and Mima or Papa are there and you ask them what the day of the week is, they may or may not know. Why do they need to know? Every day is Saturday. When you're retired, I assume every day is Saturday. You don't need to know that it's Wednesday the 13th or whatever it is, that it's Tuesday to August 17th. You don't need to know that. So you can't kind of knock somebody down on kind of this grading scale, so to speak, because they don't know that. If they know everything else, unless they've read the newspaper, most people aren't going to probably know that if they're living in, where they don't have to go to work every day and all of that. So anyways, we're talking about verbal now. So we started with awake and alert. Now we're talking about responsive to verbal. So a patient who's responsive to verbal stimuli, they're going to react to loud noises. So when you come in, you clap your hands. Sorry if that was loud. I don't think it was. But you clap your hands, or you do something to get their attention, and they don't react to that. Or if they do, then they're responsive to verbal. Then we have, and then say, so they don't react to that. Well, now we turn it up a notch. We check the pain. So someone who's responsive to a painful stimulus, they're going to react to pain by moving or crying out, by pulling their arm away. So maybe you squeeze kind of right in between the thumb and the forefinger, kind of hard, on there, just enough to cause someone to want to pull their hand back. Well, that's responsive to pain. And then the next one, but they don't do that, right? Margaret doesn't do that. She doesn't pull her hand back. Well, now we've gone on to the U. So AVPU, U being unresponsive. Unresponsive patient will not respond to verbal or painful. They're just unresponsive. So when assessing the patient's mental status, we want to consider two factors. So the patient's initial LOC. What was it like when we first initially found them? Well, when we talked about Margaret earlier, she was sitting in her chair answering questions appropriately. So we'll just mix and match our stories, right? So then we get in there and we start talking to Margaret, and then she just suddenly falls out. So she falls out right out of her chair onto the ground, and now she is unresponsive. So we want to be able to kind of map this thing out, right? That when we made initial contact, she was alert and oriented. Then she clutched her chest and she fell out of the chair onto the floor, and she became unresponsive. So it's really important to establish that baseline, much like we do with vital signs. We establish a baseline so we can kind of trend things, so we can kind of see how things are changing. So conditions causing an altered level of consciousness. There's a number of things that can cause that. Head injuries, shock, decreased level of oxygen to the brain. So hypoxia is another word for that, low oxygen. Stroke, slow heart rate, high fever. All of these things can cause someone to have a altered level of consciousness. Infections, poisoning, low level of blood glucose, insulin reaction, which can be a low level of blood glucose because maybe they were given too much insulin or had a kind of a hyper reaction and it dropped their blood sugar, which normally say it drops it down to 100, and they put in too much and it drops it down to 40. So, they have now they're having a low level of blood glucose, but it's secondary to that insulin injection that they took. So even if you cannot determine what is causing their altered LOC, their altered level of consciousness, you can help by treating the symptoms of the problem. So maybe we don't know why they have low oxygen, but we can still give them some oxygen. We can still start addressing that low oxygen. So at the next level, paramedics, the next level, maybe even at the ER, they're not going to be able to, may or may not be able to address the reason of that because maybe they have a tumor or something. Who knows? They have all kinds of stuff going on. What we can do, and what we talked about earlier, I believe it was the last one, the patient assessment, is we're going to start treating those things that we find. So we find something that's not right, and if we're able to treat that and make it better, that's what we're going to start doing. So initial treatment for this altered mental status, maintain ABCs. Everybody should remember that. What that means is airway, breathing, and circulation. We also want to maintain a normal body temperature. Obviously, we want to keep them from additional harm. So thinking about like maybe they've had a seizure or something, we want to protect them. If they're unconscious and not sustain trauma, then you can put them in that recovery position that we talked about, or use an airway adjunct to help maintain an open airway if they're doing some snoring respirations or something like that. But you do need to be prepared to suction. So if there's a chance that they may vomit or not be able to handle secretions accumulating in their airway, because that's what we do when that stuff kind of starts getting in there, our body, it causes us to cough and, hack stuff up and all that yucky stuff. But if the body's not capable of doing that, then it could be aspirated and go into the lungs, which obviously is not good. So seizures. Seizures are caused by sudden episodes of uncontrolled electrical impulses in the brain. So normally you kind of have this A and this B, and the little impulse travels from A to B. What happens though is things just start becoming erratic, and these impulses just start traveling all throughout the brain. They're completely uncontrolled. What that does is produce shaking movements and it involves the entire body. So these things usually they last 1 to 2 minutes. You may or may not, if you get called out on one on your local fire department, you may or may not see them still seizing. Typically you don't. Usually you get there and they're unresponsive, or maybe they're what we call post-ictal, where they're waking up, slowly waking up. Prolonged seizures, though, they can last for more than 2 minutes. So now patients are usually unconscious during these generalized seizures, and they don't typically remember them afterwards. Sometimes you may have someone tell you that they do, but I'm a little questionable if people can remember those things. So although seizures are rarely life-threatening, they are a serious medical condition. It can be a sign of a life-threatening condition. At minimum, people probably need to get checked out. Just if they don't have a history of that, they should need to get checked out, because that's not a normal thing. So now, a lot of times people have a history of this, and they may just need to get their levels checked out of their medication or something. So generalized seizures caused by a sudden high fever, so-called, they're a febrile seizure, and typically you're going to find those in kids and young children. Then you have an absent seizures, results in only a brief lapse of consciousness. You're thinking you've probably had several of those by now, right? We're in chapter 10, I believe. You probably had 4, maybe 5 of these, but that's not what that is. That's you just actually falling asleep. So that's completely different. That's not called an absent seizure. That's because you need more coffee, and maybe I need to be better at what I do. But that's neither here nor there. We're just going to keep on going. So what happens is these guys actually can, they start blinking their eyes and stare vacantly. So they just kind of have the nobody's home kind of thing, or maybe even one part of their body kind of starts jerking along. The whole thing about seizures that for us is we're going to monitor A, B's, and C's, and we mentioned it before, we're going to protect them. So we're going to make sure if someone starts having a seizure in front of us, we're not going to grab them and hold them tight or try to hold them down or anything, because people can become can get injured very easily doing that. What we are going to do is protect them. We're going to make sure if we can get some oxygen on them, we're going to do that. We're going to make sure they don't hit their head on something, whether that's with a pillow or a sheet or whatever. We're going to just protect them. Now, seizures can be caused by a lot of things. Epilepsy, so I guess you'd call it kind of a disease process. Trauma, head injury, stroke, shock, lots and lots of things. Obviously, drugs and alcohol, lots of things that can cause it. Decreased level of oxygen to the brain, so that's why we said we're going to make sure that we're keeping them oxygenated. High fever, we talked about febrile seizures. Typically, you don't see that in adults. I say typically, I never have seen one, and most literature you read suggests it's just going to be for small children. Infection, poisoning, drugs, alcohol, brain tumors or infection, diabetic emergencies, even a complication of pregnancy. There is a certain type of seizure that can happen for a pregnant female that is a real big problem. And then obviously unknown causes. Stuff happens many times within the body that we're not sure about. They call it an idiopathic seizure, one that we don't understand, that we're not sure why they had that. So, as we said, usually the seizure is going to be over probably by the time that you arrived. If it hasn't ended, your treatment should focus on protecting that patient from injury. We mentioned that, protecting their head, protecting their neck, doing the best that we can to not let them harm themselves, while this is going on. So the patient should be moved only if they're in a dangerous location. So, we don't want them to be in a weird place and fall off something or whatever. So there's really nothing that you can do about the patient's airway during a seizure. So back in the day, people used to cram things in there so they would, quote, not swallow their tongue and all kinds of things like that. We don't do all that stuff. Sometimes people will bite down on their tongue, and it's not uncommon that someone has some oral trauma after a seizure, but we're not going to start cramming things for the most part in people's mouths before they have a seizure, when they have a seizure. Now, once it's stopped, it's essential that you ensure an open airway, because it may take a while for them to come back out, and depending on what caused it, they could have some real issues. So, if you're able to, you'd probably want to use a head tilt, chin lift type maneuver, something that's going to be able to get that airway open. And you may need to place an airway, who knows. After you've opened the airway, if possible, you can place them in the recovery position as well. If they don't resume breathing, though, after a seizure, or if the seizure is prolonged, well, now we're going to have to start doing some ventilations, right? So you're going to get the BVM, and you're going to start administering ventilations to them. Also is administer supplemental O2 as soon as it's available. So you want to put oxygen on them, whether it's by a mask, at least a nasal cannula, but preferably by a mask, get them as much as they can. And then after the seizure, move the patient to a more comfortable private place if other EMS personnel are delayed. What happens a lot of times when people wake up from that, they're very embarrassed and feel very self-conscious about it and all of that. Not uncommon for someone to have went to the bathroom while they're having a seizure. So, there's lots of reasons people would be nervous and anxious about that. So you'll find it helpful to be knowledgeable about some more of the specific medical conditions that you can encounter as an EMR. Obviously, the more knowledge that you gain and the more medical information, the better you are prepared. The more you're prepared to help, to assess and treat and communicate all of these kinds of things, you're just a better provider. So heart conditions. The heart must receive a constant supply of oxygen or it will die. That's that thing where we talked about that time, how critical that time is. Time is muscle, time is tissue, that whole thing. So it must receive a constant supply of oxygen or it's going to die. Now, it receives that oxygen through this complex system of coronary arteries, through the heart. And what can happen with that is many times when you have someone that gets a heart attack, they have a narrowing within those coronary arteries from a result of atherosclerosis. So it becomes narrow, decreases blood flow to that, and now the tissue becomes injured because of that lack of blood flow. So that whole atherosclerosis thing that we're talking about, from that narrowing, that disease process causes layers of fat to coat the inner walls of those arteries until eventually it narrows it so much it causes some tissue damage, or it can completely just shut down. Progressive atherosclerosis, it can cause that chest pain that we mentioned before, that angina pectoris. It can cause heart attacks, even cardiac arrest. There is one particular coronary artery, the LAD, left anterior descending, which when it gets clogged up, they call that the widowmaker. And I won't explain to you why. I have a feeling you probably know, but you don't want anything in your life called the widowmaker, in my opinion. So angina pectoris. Chest pain is caused by an inadequate flow of blood and oxygen to the heart muscle. So when we use that term, that's typically what we're talking about. We're talking about a cardiac reason for that chest pain. So typically, as I mentioned before, when we were saying, asking about what that chest pain is like, it's often described as pressure, or it's heavy discomfort or squeezing, those type of things. Now this angina or angina attacks, they're usually brought on by exertion, can be emotion, even eating can cause this, but that's how these things usually will come on. So crushing pain can be felt in the chest, and it can radiate to either or both arms, the neck, the jaw, or any combination of these sites, which seems weird, but it's because of the nerve bundles and how they all run through the body. That's why you can feel this referred pain in other places of the body when it's actually being caused in one particular place, but it may be on the other side of the body that it manifests itself showing pain. So obviously, the pain is often short of breath and sweating. So short of breath, dyspnea, and then sweating, extremely frightened. Many times a sense of doom is what people will talk about. And I teach as an instructor, as well as believe as a paramedic, that when people tell you that they're going to die, trust them. And there's a good chance that they might. So you treat them as if they're going to, meaning you start doing the stuff that you're supposed to do. Whatever that means, at whatever level you are, you just start and make sure that you're doing your job properly and everything that you've been trained to do. So one of the things we want to do is for these type of patients is we ask them if they're already being treated for a heart condition. If they are, more than likely, they have a diagnosed heart condition, more than likely they probably already have nitroglycerin. What that does is it usually relieves that angina pain. So if they've been prescribed nitro, then you can assist the patient in taking one pill or administering one aerosol spray. Now, if the pain has not lessened 5 minutes after the first dose, you can help the patient take another. And if the pain is still not less than 5 minutes after the second dose, assume the patient's having a heart attack and transport immediately, which what I'm probably assuming most of you are probably working on a fire rig or an industrial setting. So you're not going to be transporting, but they should already be coming by this time for sure. Typically, you'll get there and then EMS will get there, within 5 to 10 minutes, typically. Now, whatever your local protocols are, here we go back to that statement, that cop-out statement, follow your local protocols. I can give you what the national standard curriculum is, national education standards, but your local protocols is what's been signed off by your doc, whoever that is. And that's the way that you're supposed to work, whether that's just through the state of Oklahoma protocols or you have your own, then you are to follow those. So whatever that means, maybe it's, give 2 and call for a third, or give 3, or give as many as they can take, or who knows. That's between you and your service that you're at. So a heart attack, not just the pain. Now we're talking about a heart attack. You see over there, you have damaged heart muscle, coronary artery blockage. So heart attack, or what you might hear as an MI or a myocardial infarction, that results when one or more of the coronary arteries is completely blocked. So 2 primary causes of coronary artery blockage. One is severe atherosclerosis and a blood clot from somewhere else in a circulatory system that breaks free and becomes lodged in the artery. So it's already becoming narrowed, and then you get a little clot that gets thrown, and it comes in and just completely shuts the thing down. So signs of heart attack, what does that kind of look like? So immediate and severe pain. It'll make people clutch their chest and drop to their knees. I mean, it is a lot of pain. So it can radiate from chest to the left arm or to the jaw or to the back. That's some of that referred pain that we talked about. They're usually short of breath, weak, sweating, nauseated, may vomit. If the blocked area is critical, like that LAD I talked to you about, or large, the heart may stop completely. That may completely just shut everything down, and they go into ventricular fibrillation, or even a systole, which is that big straight line that you've probably seen on a show if you've not been in the field. And that's a whole different thing. Now we're doing compressions and everything else. So, still talking about heart attacks. Complete cessation of the heartbeat. Cardiac arrest. That's when we start doing CPR. So CPR is the first emergency treatment for cardiac arrest. What we're talking about here, kind of the process, we're going to get some additional help. Hopefully we've got a crew with you. We're going to talk to the patient to relieve his or her anxiety, touch the patient to establish a bond, and then reassure the patient that you're there to help. Obviously, that's not for the one that has the complete cessation of the heartbeat. That's what stopped me for a second, because I hadn't looked at that particular part of the slide, so it threw me off. But we're talking about the first Margaret that we ran into in the chair, not the second one. So move the patient as little as possible. If you do have to move them, I need you to lift them. Do not ask someone that you believe is having some kind of cardiac condition to stand up and walk across the room to sit on your cot because you and your friends or whoever are a little bit too lazy to just lift her. Get the cot next to her, lift her up, move her over. Don't put any more additional stress on her heart than is already needed. Put them in the most comfortable position. Typically, it's going to be like a semi-reclining or sitting position. Help them take 1 adult aspirin, talking about 325 milligrams, or 2 to 4 low-dose aspirin. We're talking about baby aspirins in the event that their protocols say so, and they have that. You want to get them oxygen if it's available and your protocols permit. And then hopefully we don't get to this point, but in the event you may end up getting to some CPR, putting on your AED, your automated external defibrillator, whatever style you use, and having to go to work there. Here's a good place to stop. We'll stop here, and then we'll pick this up in a sec.